And yeah, we usually have you over.
Okay.
Set up a proposal and we should do
And then his introduction's right there.
because implementation is one of the main. So great to have you around. I'm living. Yeah.
Good morning. Oh, it worked today. Okay, so I am very pleased to introduce JD.
I did get the full intro from Steve already. So
But I am going to the different one.
okay, perfect.
Oh my God. I am going to sing and then he just, you are not allowing me to do it. Huh? I feel so bad. Okay, now so let me share something. So in 2018, Stephen Fallon joined me in Chicago, and I was one of our first approach to implementation science, and since then we met constantly with JD, and we were discussing the different theories. We were developing our logic model. We were very concerned because we didn't know if it looked good or not, but JD was always he always encouraged us to continue with our logic model, and that actually seems to work because when we got funding using that model that was later expanded to different components, for instance, including a pharmacy chain, the one-stop shop prep program, etc. So we are very grateful for the work and for your patience that you have with us. So I will strongly encourage you to have conversation with JD and show your work or your ideas because that is key for a success. So I am not going to read these two pages that they gave me. So you just read, and I'm just going to share the title of his talk. It's Implementation Research Logic Model. Oh my, that's how to prepare one for an IS or EIS grant proposal. So JD, the floor is yours.
Thank So it's kind of fitting that Mariano did the introduction for the IRLM because his IRLM, honestly, the one that his team created, I think starting in that 2018 meeting, is one of the coolest ones I've seen. So I don't have it in my slide deck, and I probably should have requested it, but I'm sure he'll send it to you so you can see a really great example. Okay, so I was asked to talk about IRLM for grant proposals. So if you're thinking about potentially not paying attention, or if you're tired and want to do emails or whatever else, my little plug is the first bullet point at the bottom. So anybody who submitted an EHE grant, one of the supplements knows this. The IRLM has been required as an element of grant proposals from NIH, AHRQ, and CDC that I'm aware of, and I'm sure there's probably others. I will fully admit we had a hand in the NIH one. Through ISKI, we pushed NIH to require it as part of the EHE supplements, but it had nothing to do with the AHRQ and CDC ones. So that's one reason to learn this. You may have to do one. And these requirements are actually not just you need a logic model. They actually say you need to use the IRLM. So yeah, for nothing else, you may just have to check a box at some point. So I also left this in here too. I can't remember what talk this was from, but I learned that this paper was the second most cited article published in implementation science between 2019 and 2023, when Web of Science was calculating the impact factor for the 2023 impact factor. I did check today. It's actually not the most cited, but it doesn't matter. Okay, so IRLM and grant proposals. So this is some of the things that I think the IRLM can really be helpful with when you're putting together an application. So some of the purposes I see, it's a really good way of organizing and visually displaying all of the many components of very complex or typically complex implementation projects. It's a place to present your preliminary data. If you're doing like an R01 or something and you're coming off of a supplement, coming off of an R03, R21, and you've done a bunch of preliminary work to understand context, to select your strategies with your partners, all of that is perfect to be plugged into the IRLM. And you can also obviously underscore and highlight that your findings are there, right? The IRLM also really offers an organizing theory. Okay, so there's lots of theories and implementation research, of course, that get very specific about organizational behavior change, individual level behavior change. The IRLM uses what we call the generalized theory of implementation research. So it's a very broad way of thinking about how do different components of implementation research, or in the paper we call them different elements that are included in implementation projects, how do they fit together and how do we understand how they are related to one another? So the IRLM has that underlying theory that's reflected in its actual structure. So we'll talk about that. So some considerations about whether you want to or don't want to include an implementation research logic model. This is, of course, considerations for when it's not required and you have to make a decision as an applicant whether or not it's, essentially something you want to include. If you're responding to an FOA, or potentially you're likely to go to a study section that doesn't have very many implementation scientists, I feel like the IRLM can kind of cut both ways. It can either be a way to really help them understand, in I think a fairly understandable structure, what you're trying to do as an implementation scientist. But there's also sort of the other side of things that maybe it is potentially a little overwhelming, or a little bit of jargon, or makes things seem excessively complicated, which other, like an efficacy researcher is not used to all the many considerations and complicated things that we're dealing with in complex systems. And so they may look at it and be like, whoa, this is like too many moving parts, too much going on. Obviously, IS reviewers, health services researchers understand the complexity of what we do, so not as big of an issue, but just consider that. This may also help you decide what level of complexity or level of completeness of the IRLM you actually include in your grant proposal. Almost every example that I'll show today is a more or less comprehensive IRLM, but I have seen and helped people generate ones that were much more targeted and didn't have nearly as much information. So I'll talk a little bit about some of the considerations for that. And I probably should have had an example or two, but to be totally honest, I have never done one that's not comprehensive in a grant proposal. And I've never had any negative feedback about it either. Every time it's been viewed as a strength by almost every reviewer. It's been underlined in many different ways as being helpful for X. So fill in the blank, people have seen it being helpful for various different things. So much like any figure that you would include in a grant proposal, a picture might be worth 1,000 words. So keep in mind that this takes up about 1/3 to half a page in a grant proposal. Typically, I feel like you can convey a lot more in the IRLM when it is done well than you can in the same amount of space if you just had to describe it via text. And of course, reviewers love a picture rather than having more darn text to read. I've been reviewing grants this week, and I will fully attest to that, having been made weary by all the small text. So yeah, if you can intersperse more figures and things, it can be really nice for reviewers to see that. I will also say though too, that the IRLM is worth next to nothing if it's not done well and not properly presented or integrated within the research. I can't tell you how many times I've been the reviewer on a grant that uses the IRLM and their only mention of it is, see figure 1 for IRLM. Sometimes I don't even say IRLM. And I've also had it where they didn't actually even cite the paper. And I'm like, I'm irritated, but I never comment about it. It's just, it hurts my soul a little bit. But there's times it just feels like it's been tacked on. And it really is not integrated within, like, where did the data come from? Why are you using it? What did it help you do? How are you going to use it to move forward? All that stuff was completely absent. I did see this a couple of times in the EHE supplements. People were just like, I have to do this. I don't know what to do with it. So I'm just going to make sure I have it so I can check the box. But if that's the case, it's not going to help you in the review because people are going to see that and be like, what the heck? So I mentioned the whole comprehensive or abbreviated. If it is not comprehensive, be sure to note this in multiple places. So I will actually like underline this when I first introduce and say like, you know, in figure 1, we present an abbreviated version, a version that is intentionally not complete, but is highlighting the most important components. I also put it in the figure caption. Okay, it's just to remind people. I think part of this is because people do expect, I think at this point, that most IRLMs are going to be more or less comprehensive. They're used to seeing them having lots of different stuff going on. So if you're going to present something that doesn't have all that, just make sure reviewers know that so they don't ding you and think like you don't know what you're doing by not having a comprehensive one. Any questions about some of these like considerations about when you would include it? And I know a lot of people in this room have used IRLMs in grant proposals because you've submitted EHE supplements, so you had to. But yeah, any questions or even comments from folks who have used it about this, some of these decisions? I'll be honest, I create mine in PowerPoint and then do a screenshot. I try to make it equivalent to, the smallest I will ever go in a figure is Arial Narrow 8.5. And I think that is actually technically like the smallest you're allowed to go, but it's not enforced. I mean, you see stuff that's way smaller than that. So I do try to like make it so that it fits that size once it gets placed into the document. I feel like that's actually a very legible, both font and size. So if you can do that, you can squeeze a lot in. And you'll see that in my examples that there's a lot going on in these, and they still fit. Steve? Yeah. Agree, as long as it's done well, right? But yeah, no, I agree. I think there are times that people have not included it. They mentioned that they're going to use it. They mentioned that in pilot work, it was their organizing framework. But yeah, if you don't actually have it, it's just has questions, right, for a reviewer about why didn't you include it. Any other comments or thoughts, Audrey? Oh, Mariana. Yeah, we've done both. So in my stuff, I typically say the IRLM is more or less a meta theory, right? It's a very high level theory. If our primary implementation strategy is like changing clinician behavior, we'll then apply a theory of behavior change about those particular strategies. But we're very clear that like it's the IRLM's theory is like the entire project. It's the whole big picture versus the more specific thing that really is, you know, what we're going to test or what the main like barrier is around clinician behavior. So totally fine to have multiple. I think it's just being very clear what are you using them for and showing that they're either complementary or embedded and not opposing in some way, which I don't think anyone's ever thought they were opposing, but you know, not everyone's that informed. So okay, as more questions come up, feel free to interrupt. So here's what the IRLM looks like. I'm presenting this just from left to right, but I'll mention a few examples where we don't always complete the logic model in this way, and I'll talk about that here in a second. So in terms of implementation context, we sometimes call this determinants. People label this barriers facilitators, contextual factors, whatever you like. I am not the IRLM police, okay? We were very explicit about this in the paper, that do what you need to do to make this fit your project, okay? Change the structure a little bit, add other components, change the language. You don't have to do it exactly like we do it. In fact, I think some of the best examples have been ones that have made modifications. So in the implementation context, plug in whatever determinant framework you're most familiar with and whichever one fits the context of your project. That's EPIS, for those who are familiar with the updated EPIS figure. I commonly use the updated CIFR. Have used PRISM. Alex and I have worked on a crosswalk called I Am for Equity that we're now using in some of our grant proposals when it's really health disparities or equity focused. That paper hopefully is going to get submitted soon, but it'll be out in the world, before too long, and we'll share it. The next thing, and you'll see if you remember the original paper, this was sort of an alternative, was to include the evidence-based thing or the health intervention that you're going to be, trying to implement. Almost everyone is using this version of the model now. So I'm going to just present this version that includes the evidence-based intervention. And part of the reason why having the intervention in the logic model, rather than just having it described someplace else, is that you want to really help the reader and reviewer understand that the capacity that is required, the support that is required for a specific intervention is related to the capacity, the contextual factors, and to the implementation strategies. So that's what these arrows are showing. I will mention too, the arrows really should be bidirectional. They are presented in a linear fashion because that is the typical logic model fashion. When you do what's called a pipeline logic model, which is what the IRLM is based on, everything flows in a straight direction. In reality, we know that's not the case, right? So there's a bidirectional with almost every arrow that's in here. On the far right, we have implementation outcomes. We modeled this particular piece after Proctor's implementation outcome framework. So you can see that basically it lines up exactly with implementation outcomes, service outcomes, and then client outcomes. I rarely put in service outcomes, to be honest. I don't really understand them. I even reviewed a paper recently that was published that basically was trying to understand what's the relationship between service outcomes and implementation outcomes. I thought it was a good paper. I still didn't learn anything. I shouldn't say I didn't learn anything. I am very little clearer than I used to be about the relationship. So I don't put those in very often, but I know folks do. And of course, we were trying to use things that were somewhat familiar to people already. And then your last two boxes are the implementation strategies and the strategy mechanisms. One thing that sometimes trips folks up, who are typically intervention developers, intervention researchers, is they think mechanisms refers to the mechanisms of the intervention. That's not the case. These are strategy mechanisms. We have a version of the logic model too that basically has a parallel box here for intervention mechanisms so that you can separate the things that the evidence-based intervention changes to achieve the client outcomes versus those things that are changed by the implementation strategy to first achieve implementation outcomes and then downstream apply. So feel free to use that either for your own, own use to figure out where do different mechanisms fit, or of course in a grant proposal, particularly if you're actually going to be testing mechanisms of both levels. So the generalized theory of the IRLM is fairly straightforward, and hopefully this very much resonates. I think almost every presentation has more or less used this kind of conceptualization, even if they haven't explicitly said it. So there's kind of three major assumptions. So implementation strategies are related to implementation context, determinants, various facilitators, and a specific evidence-based thing, right? So we are picking strategies specifically to align with or overcome barriers in the context and to support specific aspects of delivery of an evidence-based intervention. Should be pretty obvious, right? Another assumption is that strategies work through specific mechanisms to impact implementation outcomes. That's why we include the mechanism box. And then implementation outcomes are the direct proximal impacts of an implementation strategy, which then relate to the downstream clinical outcomes achieved by the evidence-based practice or intervention. Paul Estabrooks, my colleague at Utah of REAIM fame, came up with this cool little name, Cosmos. What we called this was just simply linking the elements of the implementation research logic model. I like Paul's thing of Cosmos a lot better. This stands for context, implementation strategies, implementation mechanisms, implementation outcomes. And basically it's the same thing. It's linking each of these things. Every strategy that you choose should be connected to a rationale and a justification based on the context. And then of course, as they move forward in the causal chain, they have specific mechanisms they're supposed to change in order to achieve specific implementation outcomes. So I really like one of the things that Re-AIM does, and I learned this from Paul, was they talk about reach strategies, sustainment strategies, adoption strategies. It's not just general implementation strategies, it is strategies for a specific purpose. And many strategies will obviously have an impact on multiple implementation outcomes, but often they are targeted for a first in a chain. So in order to get high reach, we need people to first adopt. So we may achieve higher reach through a specific strategy, but that strategy aimed at adoption is what's going to get us there. The reach is sort of the secondary downstream effect of having people adopt it. So here's what Cosmos kind of looks like. This is one of the few examples that I'll give where we had color coding as the way to show the linkages between strategies, mechanisms, outcomes, et cetera. You can see that we had red, blue, and green color coding. Essentially, if you look at the implementation strategies, we had three kind of broad classes or types. One was training, providers, and staff. This was done to improve adherence, to align with the CDC guidelines, to improve commitment, provider self-efficacy, reduce stigma, et cetera. And if that strategy works, it works by improving staff knowledge, et cetera. And then our primary outcome of that strategy is going to be provider adoption, appropriateness, and then some spillover into reach and acceptability. So if you actually pull this out and look at what an actual Cosmos linking is, you'll see that across the bottom. So essentially for the green, when we have peer support as our kind of anchor strategy within a Cosmos link, we're choosing a peer support implementation strategy because opinion leaders in the organization are a facilitator. There are existing champions of our effort. We want to leverage that as a facilitator. And there's a lack of external implementation support. So we need to build capacity internally by training peer support champions. If it works, that's how it works. It's done to improve reach and occurs through peer and leadership recognition of providers. I can't remember where I got this example. I may have made it up. That's why it might not make perfect sense, but you'll see basically that is the whole point of this linking. So we'll come back to the linking and how it gets shown in the logic model. We're currently doing a review, and I'll talk about this at the very end, of implementation research logic models in the literature. This is one step that is often left out. And honestly, it's one of the most important steps, and I don't understand why people don't actually do it. They basically, I think, feel like, especially for folks who are new to implementation science, they're like, I figured out where everything goes in each of the boxes. I'm done. Like that was a big enough task. Gosh darn it, I don't want to see this thing again until I get the grant funded, and then I'll decide if I want to use it again or not. But they don't do the final step of essentially linking everything. And that's where you're telling the story and demonstrating to reviewers that I know what I'm doing. These strategies are picked for purpose, and they're likely to work because of this underlying theory. Okay. Questions? Yeah.
Are you okay taking questions?
Yeah. I don't have a ton of slides, so.
So this is all thoughtful and purposive and reasonable and logically consistent, but none of it is empirically testable or verifiable, right?
Well, so that Cosmos is. So if you were to test that as a mediational model, peer support would be your exposure. You'd say whether or not it's going to improve reach as your direct path. Your peer leadership recognition would be your mediating variable. And then your opinion leaders, champions, external support, essentially are your effect modifiers or covariates.
You couldn't isolate the impact of one particular implementation strategy from any other.
But it depends on your study design. So that's where your actual research design is going to help you do that. In this case, if I wanted to isolate the effect of those strategies, let's say I just had 3 multi-component strategies. I had peer support, integration and routine care, and training providers and staff. I could actually randomly assign and use like a factorial design to test the combination of all those things. That probably doesn't make a lot of conceptual sense here because everyone's going to have to be trained. So I probably can't like skip training, but I could actually do those other 2 as 2 randomized components and then figure out the main and interaction effect of those. So the IRLM itself is not, it's not directly, but can be indirectly related to your study design. And I'll show some examples of how we integrate study design elements into the IRLM. But yeah, totally good point. Like you're not specifically, like this is not specifically a fully testable model until you layer on a research design that's capable of some of those questions.
Typically do what you're describing, randomizing each strategy sets within the design.
Sure.
Like packages of strategies.
Sure. Yeah. No. No. We, yeah, this is what I do. I mean, so the most I don't want to get into like study design talk, but I'm going to right now. So the most common type of implementation research design is basically implementation as usual versus I'm going to introduce some strategies and see if they're better. That's the most common. The next level up, which has sort of a parallel to comparative effectiveness research, is what Hendricks, Brown, and I have called comparative implementation research, which is essentially comparing different strategies and their effects. And you can do that in head-to-head trials where you have strategy A, strategy B, neither of which is implementation as usual. They're both unique novel strategies added to a context. You can do it through factorial designs. You can do it through adaptive designs. You can do it through SMART trials. If anyone's familiar with SMARTs, those test combinations and sequence of multiple implementation strategies. I have seen, I think the most complicated one I've seen, there's a fractional factorial design, I think that was done by University of Michigan that has like 14 different strategy combinations. And because you're capitalizing on power for main and interaction effects, the sample size is not nearly as large as you might think. These are, they're conceptually dense and they are also logistically complex to execute because of contamination issues, other things like that. But there's more and more examples of people testing multiple strategies within the same study design. So it's just kind of getting to that next level. And typically most of those strategies have some evidence-based, evidence-informed, et cetera. So you're really just trying to figure out which ones work best in combination. Are there ones that really don't add anything? So maybe we can get rid of those and more of a dismantling approach. But yeah, keep asking questions. I can tangent as long as we need to. So in the original paper, we sort of conceptualized using the IRLM for 4 different broad purposes within implementation research. So I have examples here. Most of the examples that I provided are ones that I was a co-author on, but there's lots of others. Like I said, there's about 330, I think, citations of this paper so far. And we've already identified about 50 or 60 published papers that have IRLMs as figures in the paper. So there's quite a few out in the literature. But in the planning process, this is typically like your pilot work, your small grant preceding a large implementation study. You can use the IRLM to work with community partners and stakeholders. Sorry, stakeholders is a bad word now. And interested parties and entities to fill in implementation strategies, to help prioritize and figure out what are the barriers and facilitators, and potentially to even figure out what your implementation outcomes and clinical outcomes could be, because what the literature thinks should be your outcome may not be what your partners are actually interested or what they want you to do. So there's always a little bit of give and take with that. We also talked about it as being used to execute projects. So serving as a roadmap, a blueprint, or more or less the protocol for what actually occurs in carrying out an implementation project. We have a couple of examples that are not yet published where people use it to track what occurs and what modifications are made. So I've never had an implementation project that went as planned, ever. Either strategies didn't work, they were ineffective, they were infeasible to do, people hated them, so we stopped them. Other situations, we realized that the strategies we picked, while thoughtful, were not good enough. They were not going to have the effect we needed. We needed to add strategies. We needed to modify who did particular strategies. So moving from a nurse to a medical assistant, for example, same strategy, but different actor. And the IRLM can actually help you demonstrate or show tracking of what was discontinued and all that kind of stuff. Not very many examples of that, but it can. I think it's more common to say that it's going to be your blueprint, it's going to be your protocol. Several examples of people using the IRLM to just communicate study results. So saying, hey, this is what we found. Here's the barriers and facilitators we encountered. Here's the strategies we used. Here's the outcomes we achieved. And that's kind of a straightforward example. The nice thing about that part is you can do that post hoc. So you can use the IRLM to organize results of an implementation project, even if you didn't use it previously to plan and execute the project. So don't feel like you've missed the boat if you're already down the path of a project and would still like to use it. We also thought there was potential to use it to synthesize the literature. So really drawing conclusions about the evidence, the implementation of an evidence-based intervention or similar EBPs in particular contexts, cross context, whatever. There are now probably a half dozen examples of this where people have used it to organize the results of systematic reviews, meta-analyses, or in the case of that first author there, who I'm not even gonna try, I was a reviewer on that paper back in 2022. They did a multiple case study approach and used the IRLM to basically pull together the shared findings and generalizable findings across multiple cases that tried to implement the same thing. So kind of a nice way of just like, showing, again, this is very similar to like reporting, but it's not just one project that's contributing data to it. It's really trying to find generalizability. So for this talk, we're really going to focus mostly on the planning and a little bit of executing, because that's really what you're going to be talking about in a grant proposal. But yeah. Okay, so grant proposal. I'm going to go through an example of how we use the IRLM to select implementation strategies with our community partners for implementation of the American Academy of Pediatrics clinical practice guidelines for pediatric hypertension. Any pediatricians, family medicine docs here who have to do this? Okay, what do you know about the AAP blood pressure guidelines?
Not supposed to check the blood pressure when the kid is coming in for a complaint, like a headache.
Yeah.
Or a GI symptom.
Typically well visits only, yeah.
Check the age appropriate range for blood pressures. And there are different cutoffs for when it's hypertension. And most people don't check the blood pressure correctly.
Yep.
I mean,
So you're illustrating my point of how many steps there are, how complex the AAP guidelines are. So that was why this was sort of ripe for a very in-depth look at what do we need to do to actually help people more or less adhere to the guidelines. This was a study that was really focused on a primary outcome of adherence to the guidelines, not just adoption. They're guidelines. They're adopted almost universally because of various reasons. But what a number of studies found is that even within 3 years, I think it was 2020 paper, found that even after 3 years in the literature, almost everyone had adopted, the level of adherence was like 20%. Meaning that they were missing key pieces. They were only performing certain aspects. So that was sort of the background to this. I don't need to go into too much of this, but the other really big thing that is important to understand is that pediatric hypertension is incredibly underdiagnosed. So it's not a highly prevalent condition. It's only about 4% of the population, but less than a quarter of the kids who actually have hypertension ever get a diagnosis. And if you look at kids who have a diagnosis, or sorry, kids who get treatment, if you don't have a diagnosis, your likelihood of getting treatment is almost zero, okay? So diagnosis is a critical outcome as well. And so adherence to the guidelines has been shown to lead to more accurate diagnosis, which again, in this causal path, if we can increase adherence to the guidelines, you're more likely to get more accurate diagnosis and find kids who have this. So we published a paper in JAMA Network Open that really showed all of this stuff in a very large sample. There was actually over 500,000 kids in the sample that we pulled from EHR data. Okay, so here again is a little bit of a flow chart of what the AAP guidelines look like. Stupid, complex, 30 key action statements plus 27 additional consensus opinion recommendations. Good luck. It's a 3-page document. It is difficult to follow. You are constantly referencing multiple tables in trying to make diagnoses. It's very difficult. Okay, so here's what we actually published. There's a paper. That's not the citation. That's the grant that funded this work, was R56, a Director's Award from NHLBI. But we published a paper in Implementation Science Communications in 2022 that was a methodology paper. So the guideline implementation example was just a case example of where we developed and applied this method. But this is generalizable and has actually been used for other conditions, other implementations, et cetera. So you can see the steps over on the left-hand side. I'll give more information about exactly how long this took and what each of these entailed. But essentially, it's a logical procedure, and you can use this for K awards, R21s, potentially year one of an R01 if you haven't selected your strategies yet. But it builds upon a lot of things we've already heard about this week. So we use user-centered or human-centered design activities. We also used a modified Delphi approach. We used matrices that are very similar to, or that are actually part of a rapid qualitative analysis. So we really incorporated a bunch of different things that a lot of implementation scientists are already doing to help select implementation strategies. And of course, we use the IRLM. So our first step was to do these design workshops. So we had 7 or 8 pediatricians in this project that worked with us over a 10-month period, met with us for 90 minutes per month, and then had maybe a half an hour of activity in between our sessions. There's a reason that it was spread apart over months, and I'll show you why, because there was a lot of stuff that happened in between the sessions. It's a very iterative process. But in this first step, the design workshops, we had them actually do 3 patient workflows. One is, how do you take vitals? So how do you actually take blood pressure, essentially, in your practice? What does the provider-patient encounter look like? So when a kid has elevated blood pressure and gets to the pediatrician, what goes on? And then obviously, if a diagnosis is given, what does the end of visit summary and treatment plan actually look like? We then had them go through what would it take essentially what changes to your workflow would be needed to be fully adherent to the guidelines. And then we said, what barriers exist in your practice that would prevent you from doing that? So this is essentially like current workflow, ideal workflow. How do we get those two to get married? And we actually did most of this over Zoom. It was really cool. We had people actually taking pictures and sending them to our HCD expert that led these sessions. And then she would put them on Zoom and look at them in real time. This was before the pandemic, but it's hard to get pediatricians together. So that's how we had to do it. So what we identified through this and using rapid qualitative analysis of the transcript of those design meetings is a boatload of barriers, quite a few strategies that people suggested, because we asked them again, what would it take to get from your current workflow to the ideal workflow that would give you full adherence to the guidelines? So they started actually throwing out some of these examples. Here, I'm going to try to get this to move. My mouse will work for me. Oh, maybe it's not going to work. No worries. So we had this list. So we were doing rapid qualitative analysis in between sessions. What we then did in steps 3 and 4 of that little flow chart, and this was done entirely by our research team, was to do a matrix of the barriers by potential strategies. So on the left-hand side, we had all of these barriers that were identified. This is only a part of the table just to illustrate what this looks like. We then had all of the implementation strategies across the top, and then we filled in the strategies and barriers that they were aligned with. So this is one thing that I like to show because I think it really illustrates that implementation research is complex, right? I've mentioned that many times. And this really shows that the fallacy of a one-to-one relationship, I identify a barrier, I pick a strategy, I'm good to go, doesn't really exist, at least not very often. In reality, a strategy is likely to address multiple barriers or the potential of having to use multiple strategies to address a single barrier, depending on how complex and prominent it is more common. The IRLM is really good at helping you show this, which is really hard to do in text. It's really hard to say, we're going to address this barrier with X, Y, Z, and A, B, C strategies. And then the converse of saying, to overcome this barrier, we've got, all that kind of stuff. So the matrices were really helpful in actually identifying this and then populating the results into the logic model. I don't know why I have this slide. It doesn't matter. I think I was just zooming in on something. So step 6 in the process was to do a survey of our clinical partners. We had them after we had all these barriers identified, we had them rate them on Laura Damschroeder's multivalent scale, which is this -2 for being a strong negative barrier to a +2. Sorry, that should be a +2, not a positive one. Which means it's a very strong facilitator, right? So we had them actually do that independently. And then we presented essentially the mean scores for those that had major, just like kind of major range. We had them talk about that to understand why it was a lot of range. Was this really like a perception of this issue? Or was it actually reflective of different contexts that they worked in? Because they were representing 7 different community health centers and 7 different individual clinics that all had different workflows, of course, different people, et cetera. We also had them do a modified Delphi approach on the implementation strategies. So they rated the likelihood that this strategy would actually be effective in your practice for overcoming the barriers that we have associated it with in the matrix. We had the same thing for how feasible is it for you to use this strategy, and a general perspective of what kind of priority should we be giving this strategy, which was kind of our way of saying, okay, you're thinking about feasibility, effectiveness, and we should also ask you, like, where should we even prioritize this if other things are created equal? So we ended up with 3 tiers. These are very qualitative tiers. They were based on quantitative results, but again, we had to, it was an N of 7. So it wasn't a whole lot of people that contributed to this. But essentially tier 1 was high priority, high effectiveness, high feasibility, or higher feasibility, I should say. Most of the strategies were not deemed as very highly feasible. So that's why it says higher feasibility. Tier 2 was moderate priority, moderate effectiveness, moderate feasibility. And then tier 3, using this as, stoplight system, the red, yellow, green. Tier 3 was lower priority, moderate effectiveness, low feasibility. We didn't have anything that was low effectiveness. And I think that's partially because they generated ideas for strategies that they thought were going to work, right? So we weren't proposing things from the literature that other people had thought of. They generated these. So then the last step is actually selecting the strategies that you're going to use, right? Your multi-component strategy package. So this is actually at step 7. I can't go back very easily, but you remember like the steps along the left-hand side. There's 8 steps, or 7. There's 7 steps in this one. We did not actually introduce the IRLM to our pediatricians until this step. So once we basically had all the information generated by them to fill in the context and strategies, only then did we actually show them a blank implementation research logic model, explain the underlying theory, the generalized theory of implementation research, and then we showed them their responses, okay? Everyone said that they understood it. We have had people tell us the opposite, that they're like, yeah, I went in and tried to like explain the IRLM to my partners and they didn't get it. It's like, you got to kind of bring them along a little bit, right? Like they're not implementation scientists. Like these are all new terms, probably a little bit of a new way of thinking. One thing after we did like some little exit interviews with the folks that participated in this, and one of the things that they said that was why I think that they understood the logic model is it's very similar to how they approach practice change and quality improvement anyway. Okay, so anybody, and these were specifically folks in practices that volunteered because they were interested in practice change. So this probably resonated a little bit because they thought like this already. But this has been pretty similar to other experiences that even in like faith-based organizations that we've worked with, they're like, oh yeah, that makes sense. Like we have a MPI in one of my projects that's a Ph.D. In religion of some sort, and then it has an MBA. And so not an implementation science background at all. And she goes, oh yeah, this is how we think about it in business too. We just use different words. So the underlying way of doing this and approaching change, seems to make sense to folks from different backgrounds. Yeah. I don't even know. We didn't really put a label on it, but there are a lot of overlap with implementation mapping, a lot of similar thinking. We don't get into as much of like the preconditions and some of the other like really minute things. But yeah, it's pretty similar. So we ended up here based on our tiering approach. This is what we presented to our folks. This is all the barriers facilitators that they had generated through our co-design and some of the other activities that we had them do. And we asked them to look at it. And we said, okay, knowing the underlying theory, do you think these strategies are actually going to overcome the barriers that they're associated with? have we missed any barriers or facilitators that should be included? And are there other strategies that you can think of that might be needed? So this is the next iteration after we got all that feedback. Everything in yellow is something that was added or modified as a result of presenting the IRLM and talking with them. So these are things that did not actually come up in all of our prior work. And we had spent, again, I think we're at month 6 or 7 at this point. We'd had almost 10 hours with these folks already. So the IRLM was actually still helpful in having them think through other alternatives, other eventualities, other factors to consider, other strategies. So I think this is basically what we ended up kind of going with in our final model. And here's what it ended up looking like. So the way that we actually built this, I put this intentionally animated in the way that we approached the conceptualization of this project. I think it's really consistent with the way a lot of folks would approach kind of strategy selection. So one of the things we knew was what we wanted to implement. We knew we wanted to have adherence to the clinical practice guidelines. So we put in all of the key components, the key pieces. Again, this is not all 30 of those action steps, but it's kind of the key things that have to be done as part of the hypertension guidelines. We then had all the barriers facilitators that at this point had been rated for their valence. They had been linked to the implementation strategies that they provided. And I'll show you what the linking looks like in 2 seconds. But this is really what was generated as a result of all this work with our community partners. We then proposed some mechanisms, not necessarily testable ones or ones we were intending to test, but we proposed some mechanisms that would be candidate. And of course, we had our implementation service and clinical patient outcomes that were also sort of done in collaboration with our community partners, but they were not formally part of the 7-step process. Okay. This actually was included in multiple R01 submissions that all got scores in the low 30s and never got funded. Still irritated about it. We had 3 submissions and we always had the same thing. We had 2 reviewers that gave it 1s and 2s. Literally, I pulled out comments to keep because someone said, this is the most sophisticated implementation grant I've read in the 5 years I've been on the study section. Not kidding. And then we had a person in that exact same round that gave it an 8.
Viewer 2.
I think it was reviewer 3, and it was very clearly a cardiologist who did not have any implementation research experience, period. And believe me, I did complain. And it happened again and again, 3 times. So I'm still a little miffed, as you can tell. But this is exactly what we put in. And this is what, I'm gonna try to move this if I can. This is what we put into our, come on, go back. How do I go back? Where's the back button? Usually it pops up on the top if I, did it go? Usually the arrows work too. I'm just gonna escape. Maybe I can't even escape. Why doesn't it let me go back?
There you go.
Okay, perfect. I said hit the arrows like 84 times. Okay, so this is exactly what we put in the grant proposal and in the publication. So you can see our little note shows all the different notations and exactly what they mean. It explains the color coding. It explains what the asterisk means on the ratings of the barriers, meaning this was significant variation between clinics, so not a uniform perception of it being a barrier facilitator, et cetera. One thing we don't have in the description is the linking. So the Cosmos linking, this is the way I like to do it. I think it works well for me, but there's other ways of doing it. Essentially, your strategies become your anchor. So once you have your strategies filled out, just label them with superscripts A through whatever. Okay, this is cute. Quite a few. So that becomes your anchor. What we typically do is we go backwards first. We say, okay, why did we pick this strategy? What is it supposed to be helping us overcome? What facilitators is it potentially leveraging in here? And then we move forward. This is not fully complete, and part of the reason, like I said, is that this was part of an this was really illustrating the process that we went through with our partners, and they weren't as much involved in this. They were involved in actually doing all of this linking, but I'll show examples in a minute that actually go all the way through. But more or less, you just move forward and say, okay, if this strategy works, what mechanisms are working through, and what outcomes is it going to be associated with? So I'll show examples again in a second here. So if anybody's thinking, dang, that's a lot of work, a lot of time, a lot to ask of your community partners, I agree. We had a lot of grant funding to do it. So we had an adapted method that we published earlier this year in a special section of Family Systems and Health that ended up being about half the amount of time in total duration and less than half the amount of time of meetings with our community partners and our clinical practice. We call it our clinical practice work group in this one to try to get rid of the term stakeholders. So the problem essentially with that initial one that I just showed you with hypertension is that the method might be a little bit onerous, given the significant time and investment from the clinical partners. The aim of this particular paper was to refine the methodology to increase its feasibility and efficiency. Like basically, could we achieve the same thing in less time? So our method actually was only 3 sessions, 3 consecutive months, 4 hours total. Previously, it was 10 months and about 12 hours of time with our community partners, okay? So we did this significantly faster. A couple of caveats. 5 of the clinicians that were involved in this project had been involved in the clinical practice guideline with hypertension projects, so there was familiarity with the method. And what we were trying to address here is a much less clinically complex issue to implement than what was done with hypertension. That's why I really emphasize the complexity of the hypertension guidelines, because it really does probably necessitate having that level of depth of investment. So the results of this modified version is this logic model. This is a P50 that is going to get funded. We're waiting NOA right now. This is what we included in the grant proposal. Exactly. So you can see the superscripting goes throughout the entirety of the project. The other piece that you'll see, because this was a center grant and has multiple components, it has an R01 and 3 R34s that we called Research Project 1, 2, and 3, and then the SP is the R01, it's called the Signature Project in this particular mechanism. You can see that there are certain places, especially in the outcomes and the mechanisms, where we differentiated, is this a mechanism that's going to be relevant to a single project, multiple projects, or all projects, right? And similarly, moving into the implementation outcomes. And part of what's really cool about this is that as a reviewer, hopefully, if we explain this correctly, they can look at this and be like, oh, across all 3 projects, I know what your primary and secondary outcomes are. I think actually in the final version, we actually listed or had like some way to notate what's the primary implementation outcome and what are the secondary ones for each project. But then we know exactly what strategies are going to be used, you know, what barriers existed for each project. And then of course we have which outcomes are trying to be achieved overall as a result of this entire prevention system and its multiple components working together. Question?
Was, this is amazing. Is this based on earlier funded work or?
This is based on self-funded stuff and like some little mini some pilot work. We submitted this grant 4 times. So this is 5 years essentially of, this is not entirely 5 years reflected here, but there's 5 years of development to get to this point. And this was about a year's worth of data collection to kind of figure all this stuff out. The one thing that I will point out here, this is one instance where we do have an indication of the study design within the IRLM. So the tiering on this one, similar to what we did for the hypertension, both of these are using a study design called the Rollout Implementation Optimization Design, or ROIO, that Hendrix Brown and I created. And what that is you basically start with the strategy package you think is going to be most effective, which is your tier 1 cluster. And then in the additional clusters, as you roll out, quite literally, in the kind of a stepped fashion, you adjust, refine, and adapt your strategy to try to get better. And the way you do that is you have pre-vetted tier 2 strategies kind of in your back pocket. So there are things that can either replace, augment, whatever, your kind of strategy 1 package. But the whole point is to try to improve. And improvement can mean taking out ineffective strategies or ones that are infeasible, but it can also mean adding new strategies, which comes from this tier 2. This is really important if you're going to do like an adaptive type design like Arroyo, because reviewers want to know, like, what are you going to do to adapt? That just can't be out of thin air, right? I can't just be like, oh, this sounds good. It has to be like pre-vetted. So you can see if we have a challenge with an orange outcome, any of them, we have orange strategies that we can pull in. So I'm not just going to willy-nilly like be like, oh, let's try this strategy. I'm going to say, okay, in the logic model, we did not have an impact on adoption of X. What's the strategy that's associated with that we could add? And are some of the strategies we used that we thought were going to affect that, if they didn't work, let's pull them out, okay? So this is a really nice little, like, almost like kind of fun puzzle. And it really shows that. Yeah.
Did it initially set out to compare cluster 1 and cluster
Nope.
2? You added cluster 2 strategies into the full package when you identified that certain barriers becoming more salient or prominent?
No, not really, but it's a longer talk to do the Arroyo stuff. It's not complicated, but it's lengthy. But again, you start with strategy package 1. Those are options for how to adjust and refine it as you move into cluster 2. Cluster 2, you'll get data that helps you modify again for cluster 3, drawing from things that you haven't yet used. So it's 3 iterations. It's not a comparative design. It's building on itself. So it's not like 2 different things. Correct. Yep, there's a mixed methods data approach to help you know where your signal is and where you're having problems, that you work with community partners to then figure out what to do based on the logic model. You mean ROIO, yeah. Rollout Implementation Optimization. Paper forthcoming, but it is published as an abstract in implementation science from the D&I contract. Yeah. Yeah. Yep. Or mechanisms. Depending on the nature of the data collection and how quickly could you see a signal. So I can't see a signal in sustainment within 4 months, but I can see a signal on a mechanism that we think is going to actually lead to sustainment, right? So in all those cases, that's why there's some complexity to this type of design. But so here's some conclusions I think about, kind of using this particularly with partners and for the reason of putting into a grant proposal. You really need to invest early in the planning process and with your community and clinical partners. You don't want to jump into this late and say, here's what I'm thinking we should do. Are you okay with, basically writing a letter of support for this? That's just not good community partnership. But it also means you can't really work with them to develop your logic model. So some of the things that I think are really important, though, is that if you do this process of engaging early, you really do get a strategy selection that is tailored to the context you're going to work in. It's not just generally going to work, or something that comes from the literature that was very different from what you're probably dealing with. In our case, these were FQHCs in Chicago. You end up with a list of vetted strategies, okay? Which basically means we've reviewed these. One step that I actually didn't say is that entire big list of strategies that they generated initially, we went to the literature to see if there was any evidence that those actually would potentially be effective. There were a few that had no evidence base at all. And so we left them in, but we flagged them, okay? And those did not make it into the final, just so you know. The other thing that this process can really help you demonstrate in a grant proposal is that you have partner buy-in for your proposed implementation plan and by extension for the grant proposal itself, okay? I don't know how many times I've seen community engaged proposals where it is very clear that the community partners have no idea what is actually being proposed. It's not in their letter, there's no relationship, or they even say, we formed this relationship 2 months ago. I'm like, oh, geez. Okay, I'm worried at this point. So in terms of the IRLM itself, though, for us, and we have used this process multiple times now for grant proposals, it has facilitated organization of our findings from the co-design workshops, focus group surveys. So multiple, mixed methods, multiple method, whatever you want to call it, approaches. All that data's got to go someplace, and this was a really good organizational framework for that. It really did, and I mentioned like all the things that got added even after we had gone through hours of time with our partners. We still had gaps in the logic and theory of change, which is something that we hypothesized the IRLM would be useful for. And actually in our evaluation of its initial launch, people did say that they thought that it was helpful for that. So if we had just gone forward without, that additional step, or potentially if we had sort of created this just as a research team, I think we would have still had gaps. So we felt pretty good that we had full coverage. And again, I did mention this already, it is relatively intuitive, but it does need some explanation and preparation to use effectively. Don't go into a first meeting saying, hey, let's start planning. We're going to use this IRLM thing. I don't know. It might work like 1 out of 10 times. But I would think that actually the process of actually populating it with their answers so that it is conceptually making sense in their head too. Like, oh yeah, I said that, I heard that, does really help this. So a couple things, there is an interactive web-based IRLM tool that is on the HIV Implementation Science Coordination Initiative website. Quite a few people like it. There are, with anything, there are some like design and usability issues that Alex probably could help us, fix. But until then, please just deal with any usability issues. But it's nice. It is pretty helpful. One thing that I also will mention is that there's interoperability between the IRLM and another method that I helped co-develop called the Longitudinal Implementation Strategy Tracking System, or LISTS. That helps you actually do tracking of strategies that are used and modified over the course of a project. So if you create a logic model, specify all your strategies, link them to your barriers, that will automatically populate when you go to lists. You won't have to add it again. So pretty cool there, and does help save some time. I mentioned that we have a project that's funded by the Margolis Foundation that is really aimed at trying to refine and improve the IRLM. So we're doing a citation analysis and systematic review of the IRLM and other logic models that are being used in implementation. Protocol paper has been submitted. We will also be doing a survey of IRLM users to get feedback essentially about what things they struggled with, what would be helpful for them to use it more effectively. As part of our actual data extraction and coding in the systematic review, we'll be generating a rating tool as well as an updated guide to hopefully enhance the quality and utility of the IRLM for users. And then for folks who are familiar, our worksheets that we created back in 2020 are a little out of date. They're still the original CIFR. There was no worksheet on mechanisms because in 2020, there was like one paper on mechanisms. And we didn't even feel like we could give a paragraph to give guidance, honestly. So we just left it out. There is going to be an expansive, more expansive implementation outcome worksheet that'll be based on the implementation outcome framework, REAIM, and others. Rebecca Lennox-Hall and Rosemary Meza, who have been involved in the implementation mechanisms projects with Kara Lewis and others, are going to be, or have actually created the worksheet for mechanisms. We're also going to be pulling in strategies beyond the ERIC compilation, knowing that that is not exhaustive, and there are other compilations that have additional strategies. And then we're going to have other things like the crosswalk of determinants framework, IAM for equity that I mentioned earlier is going to be incorporated as well. So people have other options and just more flexibility. So I wanted to end with this. I don't know if anybody wants to mention and talk about this as we go through questions and comments, but just for those who have actually used it, was it useful? Did you actually find that going through the creation of it or the inclusion actually helped your grant proposal or your own understanding and logic of your project? And honestly, if anybody has feedback or has received feedback from reviewers about it, I would love to hear it, whether that's an email, during lunch, whatever. So I'll stop there and we'll chat. Yeah.
Thinking about things that I've struggled through that. And then one of my questions, which is a little off topic around the Royo stuff, but could you almost do the opposite? And it's that kind of adaptive design. So I'm thinking about partner needs, if they want to roll something out like right away, like give us the training, we're gonna go. Could you kind of do the training, go collect data, have some sort of threshold that it's not meeting, and then do a plus, like
You could. Yeah, folks have done things like that. I think the thing that's the beauty about the Royo is that you're putting your best guess forward right from the beginning. And the hope potentially, you know, if you have, just hypothetically, if you had 4 clusters, right, and like 4 opportunities. So basically your opportunities to improve are n number of clusters minus 1. Okay, so if you have 4 clusters, you have 3 chances because you're using data from cluster 1 to inform cluster 2, 2 to 3, 3 to 4. You have 3 chances. In an ideal world, cluster 1 works pretty well. Okay, because you did all this work, you kind of guessed right. You can add some things that maybe are more expensive or maybe a little bit more onerous, see if it's actually cost effective. All Royos have a cost effectiveness component, by the way. So you can actually see cost-wise whether or not it was actually worth adding this additional strategy. In cluster 3, if you've improved, in cluster 3, you can start pulling strategies out to, again, increase cost effectiveness, increase feasibility, and then the cluster 4, the same thing. So that's kind of the ideal world, is that you're actually not just like adding and trying to like get maximum benefit. You're trying to find the most cost effective and highest utility package of strategy.
Get to tier 1 with your partners, but maybe you have their buy-in now, because given the training. So they might already be rolling it. I like a scenario like that, where the need is really high, they want to.
Yeah.
Like the safety planning direction. Teachers need to get trained in safety planning. There has to be a training. We don't have 2 years to find our tier 1. Maybe if we give the safety planning intervention now, we take our 2 years.
I think you could. I think it just changes a little bit of the hypothesis or the some of the underlying assumptions, but I don't think you couldn't. Yeah.
Thinking about like some of the other tools we learned about, like mapping or but like you could use that as parts of your steps, right? Like how
Yeah.
would you put together some.
So there's 2 ways you can use implementation mapping with IRLM. One is that you generate the initial IRLM, and then I didn't show the example, actually the one we were talking about yesterday, but there's examples too where we have, you know, a two-arm trial where there's like 5 or 6 strategies that we're going to apply across both arms. So training, we provide them with, you know, potentially we change their data system so that they can actually do the intervention. But some of those things are just like necessary to launch, right? That takes people from like implementation as usual to like almost plus implementation immediately in the control condition. And then you have one strategy that is in the other condition, and you can isolate the effect of that one strategy. So with implementation mapping, I would probably want to potentially create the IRLM, have that as a proposal, and then go more deep into the one strategy, right? So I'm gonna like actually get much more information. You can also go the opposite and do a bunch of implementation mapping and then put it in the logic model, but there's gonna be potentially a number of strategies that you didn't really need to go through all that process with IM. And so there's always a little bit of a trade-off of just efficiency. Yeah, okay.
Might be very straightforward, but your guidance on how does that affect the current? But
Yeah.
there's pathways that happen.
Yeah. It does. So you're more or less, if you think about, especially when I didn't show this example, but if you have the one that has implementation outcomes, or sorry, implementation strategies, implementation mechanisms, implementation outcomes, you essentially then repeat for adjunctive intervention mechanism, what is the outcome of the adjunctive intervention? And you have strategies, this is where it gets more complicated. You have strategies to help you implement the adjunctive intervention. So you have multiple, you like add a third level. It does get more complex. The paper does have an example of that with PrEP as the like health intervention that has 2, I think in that case, we actually put 2 examples of adjunctive interventions in there. But essentially when you do that, you're just getting much more specific about, okay, what strategy is used to implement PrEP and what's used to implement the adjunctive intervention. And then of course you want to have those specific outcomes of how is the adjunctive intervention working? How do we know? And the same thing for PrEP. So if you skip some of those steps, and this has been always like a little bit of my issue with some implementation work, especially in the early days, like people would do like hybrid type 2s and hybrid type 3s, and they would say my primary outcome is effectiveness. And it's like, yes, of course you want to reduce the public health burden of this thing. But if you basically ignore the whole implementation pathway and you don't have a good outcome, you have no idea why. Is that because your health intervention didn't work? Or is it because your implementation sucked? Or is it both? So that's where you really have to have these like really high level of specificity. And I do think that having that well thought out and displayed really can help reviewers too. It helps you, I think, too, just organize your own thoughts and how you're going to like present your argument and your rationale for what you're doing. But it really helps reviewers be like, oh, I get it. You're measuring adherence because of the adjunctive intervention. You're measuring, new HIV infections as the effectiveness of PrEP itself. However that goes. But yeah, it does get more complex.
One of the many ways in which I'm appreciating your presentation is informing us what kind of pilot data is necessary to have a compelling implementation science grant application. I come to implementation science through clinical intervention research and treatment development research.
Yeah.
And I think when the empirically supported thing that you're trying to implement when it's your thing, you probably have access to a lot of that pilot data already through the experience of running the effectiveness trial.
Yeah.
Or the efficacy
You
trial.
should a little bit, yeah.
I was just thinking about what you just said. You can't really do an effectiveness trial without any consideration for implementation. And I'm sort of squirming as you say that. I'm pretty sure I've done that.
Well, I think what's typical is people, they assess fidelity. And that's their like implementation, like consideration. It's like, oh, if it doesn't work as well as we thought, it's maybe because we didn't implement it like it should have been. So that's most typical.
In global mental health, where I do a lot of my work, I've always been concerned in effectiveness about sustainability.
Sure.
Sustainability is obviously an implementation science
Yep.
construct and concern. But for example, in a study that started nearly 7 years ago, where nobody was talking about implementation science, we task shifted to peer counselors. We got Ministry of Health relationships. We implemented in clinics. We got clinic partners.
Strategy.
Right, and we didn't call them practice champions, but of course that's what we were.
Yeah.
We did stage rollout. We did lots of bait and switch when things weren't working.
Yep.
Very little of which we collected data around. This is just to support our effectiveness.
Absolutely.
Yeah.
Yep.
But also, I think one of the things we're kind of good at is knowing what kind of pilot data is necessary for an R34 treatment development, for an R1 effectiveness, or even an efficacy effectiveness hybrid. But it still seems to be a floating target a little bit as to what kind of pilot data you need for an implementation science.
Yeah, so I think, 3 or 4 years ago, 5 years ago, it was not uncommon to have aim 1 be, we're going to assess barriers facilitators. Aim 2, we're going to like do our final selection of strategies. But the grant proposal itself includes some strategies that are likely because of things that from effectiveness research, or things that you can just discern from, hey, here's the actual needs of a particular intervention. And then the final aim is basically do the trial, right? And see if it actually worked. My sense is there's a little bit of a shift happening, that some of that initial work of figuring out the strategies and doing the contextual assessment, reviewers are a little bit less comfortable with that now, because they're like, there's so much data out there. There's so much information about the kind of barriers that you can expect. So I do a lot of stuff in integrated primary care, both for adult and for kids. The same barriers exist for any intervention almost. Like, there are some specific ones because certain interventions have specific needs. Like if I have to do a clinical decision support, to help, like an intervention includes a CDS, obviously I have to have a strategy around engaging with IT, changing the IT infrastructure. That may not be true for every intervention, but if it is, that's a barrier, period. So you can go to the literature and look for similar kinds of projects in similar settings and probably get a really good handle on what barriers are going to exist. As part of ISKI, I direct the Systematic Review Corps. We've published, I think, 5 or 6 papers now, maybe more, on barriers to implementation of X evidence-based HIV prevention or treatment intervention, and then split them all by the different contexts in which they've been delivered. And it's not surprising that you see the same stuff occurring over and over and over again. Staff, time, costs, policies that help us actually support it. Like, you're seeing the same stuff. So there are situations where there's enough literature that you don't need to do a ton of your own pilot work. You may need to work with your community partners to say, hey, does this exist in your system? To what extent is it a major barrier versus not? Because if I go to Kaiser primary care, Kaiser Permanente, or I go to an FQHC primary care, they're going to look different. They're probably still going to have similar challenges, but like the prioritization or degree of different barriers and facilitators is probably a little different, just given the nature of those settings. But really kind of just like demonstrating that you've considered the literature, you've maybe done your own primary data collection, and you've made sure that it actually aligns with the context you're working in. That's fine. I've seen several R01s get funded in recent years that I don't think did any of their own primary data collection as preliminary work, but it really was drawing from prior studies, existing literature, et cetera. And then, yeah, just working with their partners to say, yeah, this actually does apply to us. And similar with strategies, I think as a reviewer, I have a really hard time evaluating a grant that basically doesn't know what strategies they're going to use. And they'll say, like, we're going to do a cluster randomized trial and our primary outcome is reach. And it's like, okay, I don't know what strategy you're using for reach. And if your like experimental condition is a strategy that ultimately ends up being a strategy that is not directly associated with reach, then you have the wrong design, you have the wrong outcome. And as a reviewer, I'm like, I don't feel good about that. So I'm definitely not going to review it as positively as somebody who has done this work, knows for sure this is our experimental strategy condition, and here's how we're evaluating it, and here's what our outcomes are. Ruben.
Congrats, man. It's beautiful work. It expresses so much of your dedication and discipline. I just want to thank you for normalizing the complexity and the chaotic nature of this work. I think I was trained as a trialist, right? And internal validity was the thing.
Yeah.
And historically at the time for us was this cultural relevance. So we needed highly controlled studies and all that to get there. But we've evolved and we're in the midst of this scaling up. But I see many of my colleagues really being averse to when you said, you know, you put the barriers and the strategies and said the fallacy is that this is simple. I mean, that message is so important because I see it with scholars at all levels, early career to senior, that being a major barrier in the way they approach this.
Yeah.
It's like perceived as a threat or something to avoid rather than its reality.
Yeah.
Adapt.
Embrace it. Because it is what's going to, you know, no matter how pristine and like simple you can present an argument in a grant, the reality of actually doing it is not ever going to look like that. So I'd say embrace it.
So I just want to thank you for saying that with such clarity because we've been trained to avoid that, many of us.
Yeah.
And it just gives me a lot of hope that for new folks that are moving into this pragmatic way of embracing reality.
Yeah. And I mean, we started actually talking about this, you know, in the hybrid study talk, but Ruben's point makes me think of it again, that there is a fallacy too that all implementation projects are pragmatic and that all efficacy projects are tightly controlled explanatory trials. That's not true. Like there exists, implementation trials equally exist on the pragmatic to explanatory continuum. And so there are ways that you can select sites, ways that you can, you know, actually isolate implementation strategies in ways that make it look a little bit more like an explanatory trial. Not to be confused with an efficacy trial, because efficacy is about determining the effect of an intervention, but explanatory meaning I want to know, does this strategy affect this outcome through a purported mechanism? And there are ways to do that. When you do like basically, you know, as was pointed out in your question earlier, if you're doing a package of strategies against implementation as usual, and those are your two conditions, even if you are measuring multiple outcomes and you think they're conceptually tied to specific strategies that you selected, you still are at a major disadvantage for understanding exactly which strategies contributed to which outcome because they're all being thrown at the problem simultaneously. the reality of this work of implementing is that's what happens. So there's nothing wrong with that kind of a study. It's just that's a very pragmatic study versus a more explanatory study that tries to isolate the impact of a particular strategy. That's part of my other big like design and research design talk, but useful to keep in the back of your mind. I'm being told that I need to get off of the stage here so y'all can eat lunch. So thank you.
Okay, thank you. So we have lunch now until 1 p.m. And for the lunch and networking activity that we'd like to do today is just to revisit our What is Equitable Implementation Science poster in the back. We're envisioning that to be exploding with red Post-it notes. So we have a long ways to go. Okay, we can put up a couple other prompts, but based on the new prompts and what you've learned and taken home from all the presentations so far, we'd love to make that happen. So thank you. We have until 1 p.m. for lunch. Thanks.
You'll have to.